one.
Hello, everybody, and I'd like to welcome you to our Outbreak Management Advisory Board, whether you're taking part in the meeting or watching along at home. You're all very welcome. As well as giving a welcome, first thing is just to record any apologies that we've received today, and we've got a couple to go through. So I'll ask Tracy to take us through those, please.
Chair. So there's quite a few today. So we've got apologies from Simon Dennis from the Office of the Police, Fire and Crime Commissioner. Apologies from James Farrer at the Local Enterprise Partnership, from Ian Floyd at the Council, from Ian Humphreys at First York, from Zoe Metcalf from the Office of the Police, Fire and Crime Commissioner, and Nicole Hutchinson is substituting, from Phil Mettam at the CCG, from Stephanie Porter at the CCG, from Sharon Stoltz and Fiona Phillips is substituting, from Dr. Sally Tyra at the Local Medical Committee, and finally from Lisa Winwood and Mabs Hussain is substituting.
Thank you very much for that, Tracy, and equally welcome to substitutes. And I know as the meeting goes on, we might be joined by a few others who are presenting particular reports, but we'll record those apologies in the minutes. First agenda item then is declarations of interest. So I'll give a couple of seconds in case anybody wants to declare any additional interests from the agenda. I can't see any electronic hands up, so no additional ones to declare. Thank you very much. Which then takes us straight onto the minutes of the previous meeting, and that was on the 26th of January. So again, I'll just give a few seconds in case there are any issues or matters that colleagues want to raise. If not, I'll assume that we're happy to sign off those minutes unless you indicate now. So thank you very much for that. I'll sign those off. We then move on to agenda item 3, which is a presentation that Fiona Phillips is going to run us through of a data summary of the pandemic period, and I'll hand straight over to Fiona.
Thank you, Chair. Small presentation in terms of where rates are now. This is kind of a look back over the last couple of years and a bit of the pandemic in numbers for York. So if we go on to the first slide, this kind of shows how the pandemic has played out across York since back in end of February into March of 2020. So across that time, we've had 59,026 positive cases of COVID. It's actually a lower rate than England as a whole and lower than the regional average. So you know, positive that we've had less impact, as it were, in York. I will just, you know, what you can clearly see on that epidemic curve is numbers are currently going up. So whilst we're talking about moving out of the outbreak response kind of period for COVID, obviously COVID hasn't gone away and there still are high rate of cases in York. But some of the slides that I'll go on to show will kind of demonstrate why we're now perhaps moving out of outbreak response mode. So if we go on to look at the next slide, this shows us a little bit about numbers who've had more than one infection. So at the start of the pandemic, COVID was kind of seen as a one-off event, but a lot of people will now know people who've had it more than once. So we can see almost 8% of our population in York have had COVID for the second time, and we're now starting to see people who are having it for a third time. And as we go on and start to live with COVID, we will potentially see it as a common infection and something that we have to accept and live with. So if we look on then to the next slide. So throughout this pandemic, there's been an awful lot of testing has happened. Some of that because people have had symptoms, but some of that also because people have been doing regular testing to monitor if they're safe to go to work, if they're safe to meet relatives, etc. So almost 80,000 positive tests in our population. And that breaks down as mostly through pillar 2. So just as a reminder, pillar 1 are those tests that happen in hospital setting, and pillar 2 are the tests that either happen, they're either lateral flow tests or a PCR test, which people will have usually have had done up at Popperton Bar or Wentworth Way. So the lateral flow tests, about almost a third of tests at pillar 2 have been lateral flow tests, and over half PCR tests, and there's a percentage in there where it hasn't been recorded which one it was. And as people will know, we've throughout the course of the pandemic, at various times, we've had our own testing sites. We have 3 at the moment, but throughout the pandemic at the height, we had 7 testing sites. So at the university sites and in various community locations. And in that time, we've had over 70,000 appointments where people have come to have lateral flow tests conducted at those sites. So it's been a massive effort from our public health team of delivering those sites, but also of our residents engaging in that and coming forward and having those tests. So it's been quite a phenomenal effort. On to the next slide. So a little bit about variants. Obviously, at the start of the pandemic, it was just COVID. There weren't any variants. So what you kind of don't really see in here is that kind of original COVID, as it were. But if you remember back, we had the Alpha or the Kent variant, which actually was reasonably short-lived, although it did kind of present a new challenge at the time. The first kind of real different variant we'd seen from the original COVID variant, but reasonably short-lived because we then had the Delta variant, which kind of caused us to have a real surge in cases over the kind of December, January 2021, and really took over as the new strain. So 40% of cases being that Delta variant. And then, of course, we had a few little minor other kind of strains of the Delta. So you can see Delta Plus being the main one there. And then we had the Omicron variant, which came in from December time of last year, and again that pretty much wiped out the Delta variant. So we had the Omicron BA1, so almost half of the cases we've seen now have been Omicron. And what we're starting to see a little bit of now, and we'll probably see more of, is the BA2, which is just a variation of the Omicron variant, and we've got about 4% of cases now. Potentially BA2 will take over and become the next dominant strain. So we're likely that we'll see more variants as we go through, and the UK HSA will be monitoring those variants, and obviously we're hopeful that any new variants will continue to be reasonably mild and responsive to the vaccinations that we currently have. So if we look at the next slide. So this shows us what's happening in terms of people in hospital with COVID. So obviously we had a peak right at the start of the pandemic where we didn't have any vaccinations, and we had a lot of people in hospital being treated with COVID. You can see the green line there along the bottom, which is people in ICU. So these were people who were extremely unwell with COVID, and we had a bit of a peak there right at the start. That second peak in hospital admissions in the middle of the graph, that related to what I mentioned previously about that Delta variant that came. At this point in the pandemic, the vaccination program was only just starting to really roll out. So we had some of our more vulnerable care home residents vaccinated, but it hadn't really gone down the ages at that point. And so we did see a peak in hospital admissions. And again, you can see a slight peak, not quite as high, but there was an increase in patients in ITU at that time. And then kind of moving over to the right-hand side of the graph, what we can see now is, again, with high rates of Omicron circulating in the population, we have a high number of people in hospital who have COVID. The difference here is you can see that the green line along the bottom it has been pretty flat, so we don't have we didn't see that peak in people seriously unwell in ITU with COVID. And what we do know about the people in hospital with COVID is that many of them are in hospital for something else. They're routinely screened when they enter hospital. And they are then found to have COVID. So they're not being treated for COVID, but obviously that does create additional demands in terms of how the hospital then manages those patients knowing that they have COVID. And then on to the next slide, it kind of demonstrates this again. So just looking at deaths. So throughout the whole course of the pandemic to date, unfortunately, there have been 469 of our residents who have died from COVID. We can see that that's lower than the national rate. But obviously any death is obviously a sad occurrence. And if we look at the next slide, this just kind of shows those deaths over time. So what you can clearly see at the start of the pandemic, an increase in deaths. So the red line along the bottom is deaths from COVID, and that happened again when we had the Delta wave. So although our hospital admissions look high, as I say, many of those people are not in hospital for COVID, and what we haven't seen in this more recent phase of the pandemic is that we have not seen that peak in deaths, which is a real positive and is due to the vaccination program that we have. We've now got good uptakes. As I say, in that Delta wave, we hadn't really worked through those age groups to give good coverage and good immunization within the population. So we're in a very different position now, and what you can see on the blue line at the above, when you look at kind of all deaths, we're not seeing our death rate being particularly higher than we would expect at that time of year. So that's a really positive move and a place to be in now. So then just going into the next slide, just kind of having a look at some of the other aspects throughout the pandemic and things that as a city that we have done. So over 3,000 test and trace support payments have been paid to residents. So this is where we make payments to support people to be able to self-isolate if they've had a loss of earnings, for example. So a huge number of residents who've been supported in that way. Also, the council have administered the Omicron hospitality and leisure grants, so over 800 of those. And also earlier on in the pandemic, grants paid out to businesses who were unable to open, so over 5,000 of those being paid. So quite a lot of support given to our residents and our businesses in the city through the course of the pandemic. So if we look then on the next slide, So, as I mentioned, the vaccination programme is really what's got us to where we are today. It's been a phenomenal effort from the NHS to do this programme, probably the biggest vaccination programme in most of our lifetimes. And you can see here the uptake rate across the different age groups, but just the sheer kind of number of vaccinations. So over 150,000 people having had at least one dose of that vaccine. And then obviously, as we've gone through the vaccination programme, moving down into the lower age groups as well, so the 12 to 15-year-olds, so almost 6,000 in that age group having had a first dose of the vaccine. And clearly the vaccination programme isn't over, and I'm sure others may talk about this later, but currently doing the 4th booster dose now for our older residents and those with clinical vulnerabilities, and shortly in April be starting on the next lower cohort, which is our 5 to 11-year-olds. So it's an ongoing process, but something that as a city we should be really proud of, how well that's been rolled out and offered to our residents. And then just on to the next slide. This again shows how we've done that by age, and obviously, you know, it's first dose, second dose, and booster doses as well. So a really good uptake, particularly in our more vulnerable age groups, but actually across all age groups, a good uptake. And you know, it's an evergreen offer, the vaccination as well. So I'm sure we'll get more people who continue to come forward and have that vaccination as well. And then if on the next slide just kind of shows that again by different breakdowns, if you want to move on to the next slide. Yeah, so we see that by ward. We've spoken about it many times in this meeting about the lower uptake in some of our wards, and again that is ongoing work that we will still continue to support. How do we target into those wards and ensure that we get good uptake across all of our populations? So that will still be ongoing work. And then if we just move on to the next one, which I think may be the last one. The other piece of work which we've obviously clearly been leading on within York is our contact tracing service. So that has now finished, now that there isn't a legal requirement to self-isolate. But from when we started offering doing the contact tracing work back in March 2021, in just under a year, we've actioned over 17,500 referrals, and it's not just been doing the contact tracing that team has done, it's also been answering the questions about COVID, offering the support, making sure people know where they can get help. So a huge piece of work that the public health team have done in the city, and we've had really good uptake from our residents who've engaged in that piece of work as well. So again, a really positive piece of work. I think that might be the last slide.
Yeah, it seems to be the last one.
Yeah, so happy to answer any questions on that, but I hope that just kind of gives a picture of the scale of the effort that the city have pulled together to deliver over the period.
Thank you very much for that, Fiona, and open it for any questions or comments. But just to repeat as chair and ask for that thanks to be minuted for the huge amount of work from public health teams to volunteers to NHS, primary care, community voluntary sector business colleagues in pulling together in that effort. And I think it has been such a whirlwind for everybody of ups and downs and changes that actually I still find myself forgetting quite how much has been done and how many changes and the level of service provision that's going on. And indeed, Only this morning, I was talking to neighbours who were really, really pleased to have just been to our local GP surgery and have had their fourth jabs this morning. And it's ongoing, isn't it, in that sense? But I'm sure that is shared by everybody, and we'll make sure is minuted. Alison.
Yeah, I would echo that, especially the public health team, who have been phenomenal and relentless. I have to say, they haven't stopped. So thank you to Fiona and her colleagues as well. You've been brilliant. My question is just about the booster, Fiona. So there's quite a drop from those having a second vaccine to the booster. Is that just a timing issue, or is it people just can't be bothered to get the booster? And is there any link between the numbers going up through the roof that we've got, less people potentially protected?
Yeah. I mean, I think some of it is a timing thing, and some of it is due to because we've had high rates of COVID as well. So you can't have your vaccine immediately after having had COVID. So, some people who may have been almost about to be ready to get the booster dose may have then had COVID, and so now they've got to wait before they can have it again. There potentially is something as well, which we pick up. So because we've got the vaccination program, but it's mild in the vaccinated. So what we just have to be careful is that people understand that it's a mild disease because we've got a vaccination program. So we just have to be careful that people don't think, oh, well, I don't need to get my booster now because it's only like a cold. It's quite mild. So there is still work that we need to do in getting those messages across that vaccination is still important, and that's why people are not becoming unwell. So yeah, there is still work to do on that.
Thank you very much for that. So with that, obviously, we're noting all of that information and the presentation that Fiona gave. And Fiona, will that be attached and published if it hasn't been already? Yeah, great. Thank you very much.
Yes, that will be online, so people will be able to get that.
Thank you, Fiona. And I'm very pleased. I've just had a little note from Tracy reminding me that I've forgotten that, Sian, I somehow, because there's a little bit of yellow on your other side of your screen, I'll blame that. I missed the yellow hand. Sian.
I wanted to say the same as my colleagues. I think it's amazing what everybody has done, and particularly the public health team, who have been very much holding the ring on this and just keeping us all going through this. I think that the question I had was for Fiona in terms of, we know so much is coming to an end now, but we also know COVID hasn't gone away. So I guess, and this morning I was in a presentation where Kevin Smith did an amazing presentation about variants, about current case rates, about how do we learn to live with this? How do we accept the fact that this isn't going away? This is going to be in our population. And unlike the common cold, it is still a deadly virus for far more people than colds and flu are. So I guess my question for you was, with all this coming, what are the messages that public health want us to be promoting, sharing with people, so that we can weather the Omicron variant BA2 storm as well as possible as a health and care system?
Yeah, so I think, going back to what I just said about vaccination is still really important. So we don't want people to become complacent and think, oh, it's only mild, I don't need a vaccine. So that's obviously a key element. I think for me that we are moving to this next phase, and a lot of people will feel quite nervous about that. So I think there is something that we need to do to help people through that. We've spent 2 years telling people you can't do this, you have to be careful about that, and now we're kind of moving to, now you can do this. So we want to give people the confidence and help them to understand why, you know, a month ago we were saying you have to test twice a week, and now actually we're saying, you know, we're not doing that now because it isn't sustainable. Doing all of that testing at a time was absolutely the right thing to do and was necessary, but we are, you know, we're not going to be doing that for the rest of our lives. So, you know, it is about giving the people the confidence to feel able to do that, and to kind of have faith as well that we will be monitoring, you know, so if a new variant that is more dangerous comes along, that will be picked up. For example, if we start to see that there are people seriously unwell in hospital with COVID is going up, that will be picked up. So, you know, I really hope that this doesn't happen, but I guess we all need to have in the back of our minds that something could happen still within the pandemic where we have to stand back up some of the measures that we've had in place previously, and we would absolutely look to move swiftly to do that for our residents in York, whether that were a national directive or whether we were seeing something locally in York changing the picture that we're seeing now. So I think it's just supporting people through this for some people.
Jamila.
Thank you, Chair. Just a quick one for Fiona. It's a really good presentation, Fiona. Thank you for that. And lots of changes ahead. I was just wondering, at the moment, we're seeing an increase in some COVID and some of our staff in our provider and market. Is there going to be any further guidance? Because I think at the moment we know, because testing is still going on at a pace, and has that changed over the next few months? Do you think there's going to be any more particular guidance for both our internal provision and external providers?
Yeah, so we are expecting some more guidance to come out on the 1st of April. Which will particularly talk about the next phase of living with COVID, but particularly some of those high risk expectation is particularly around testing in those settings. So yeah, unfortunately it's not being published until the 1st of April, which is kind of when it will be implemented. So would have been nice to have had it a little bit earlier than that, but we'll live with that. So yes, that guidance will come and will direct, you know, this next phase of the pandemic.
Thank you very much for that and your question. So we'll obviously note all of that information and presentation. Thank you to Fiona. And that takes us on to agenda item 4, which is an update on the COVID vaccination programme. And welcome to Mike. I'll hand straight over to you.
Yeah, thanks, Keith. So just really to recap where we've been through the vaccine programme, you've obviously all seen sight of the paper that's been circulated from Steph Porter. As we reflect back, I guess we started in December 20 with a multi-sector offer. We had Nimbus Care working out of Askham Bar, delivering both local and national vaccine services. But it wasn't just Nimbus Care. I think it's worth noting that practices were involved in this, the hospital and community pharmacy, and obviously we've had a number of pop-up sites around the city responding to areas of low take-up, and of course at our universities, who were fantastic to work with in terms of delivering vaccines to students. The numbers have been, I think, phenomenal. We've delivered over 600,000 vaccines at Askham Bar alone, and if you look at the tables in the paper, 82.74% of our population had their first and second jabs and therefore fully vaccinated, and of those 88% have had the booster as well. And there's been particularly good uptake in those more vulnerable in society, sort of older, higher risk cohorts, with a bit of a drop off in the under 50 age bracket. Obviously, some people are still not vaccinated. There are, reasonably significant numbers still unvaccinated, but hopefully we're still going to be offering a service for them, what we're calling an evergreen service, for those people to drop in at any time to get vaccinated should they need it. The December booster campaign, was very short notice, but elicited a phenomenal response from the city. General practice pulled together, stopping some core services really to deliver that campaign at very short notice over the Christmas holiday period, and we achieved really good numbers of vaccinations during that time. Moving forward, we're now offering vaccines for the 5 to 11 age group, should they choose to have it. And we're in advanced discussions with NHS England about the ongoing commissioning of both the National Vaccination Centre at Askham Bar, but also the local vaccination service we deliver on behalf of PCNs. Nimbus Care has been asked by a number of PCNs to deliver that part of the programme for them. And essentially, it's going to be in 3 parts. There's going to be this evergreen offer, which enables us to stay open. Our contract is going to be rolled over for a year, I think. So until the end of March 2023, where we'll be able to stay open and offer vaccines to those who haven't had either a first, second, or booster dose. We'll be delivering, and in fact, I've already started delivering the booster program. So the spring booster program started this week, delivering vaccines to our over 75 cohort, those living in care homes, and anyone over 12 with a weakened immune system. And we're preparing to deliver the potentially a further booster campaign later in the year, but obviously waiting for JCVI guidance around that. And then the third element is preparation for surges. So, should levels go up, should we have new variants, we're on standby and ready to mobilize really quickly to vaccinate the people as and when needed. I'll talk a little bit later about the impact on health and social care staff. I think the current high levels of COVID are having an impact, both certainly in primary care and in secondary care, and that's affecting the routine care delivery. But perhaps I'll talk a little bit more about that in the Living with COVID agenda item. So I'll stop there, Keith. I'm very happy to take questions.
Thank you very much for that, Mike. Open it in case there are any questions or comments, and I'll go to Pete first.
Thanks for that, Mike, and apologies, I dropped out before my computer crashed, so I hope you can all hear me okay. Just in previous reports, we've had a breakdown by wards in terms of where the vaccinations are, where the uptake is strong and where it's weak, and there was a correlation between the poorer wards and low vaccination uptake. Just wondering what work's been done on that and if any inroads have been made into those areas.
Yeah, I think we can't take our eye off that, Pete. I think the patterns, continues. I think clearly the work that public health have been doing has been fantastic. The contact tracing and knocking on doors, etc. That has been fantastic. The work we've done with pop-ups, going to those areas and offering services close to their homes. We'll still do that as and when required moving forward. There's always been a sort of slight anxiety around access, but I think our sense is, as we've explored this in greater and greater depth, we're not convinced that that's a massive factor, but nevertheless we're still prepared and ready to deliver pop-ups in areas of low uptake as and when needed. What we have found though is when we do those pop-ups, the uptake isn't as high as we would have expected, perhaps, which means that access perhaps isn't the be all and end all in the rationale for this happening.
I can just follow up. I think last time we talked about working with ward councillors in those areas to try and break down some of those barriers, and I'm not sure that's happened. Did any of that work happen?
I'm not sure. Do you want to come in on that?
Yeah, I can come in on that one. So my colleague Anita Dobson in the public health team has made contact with the councillors in those wards where there has been lower uptake, but it hasn't really led to any tangible work as such in terms of what we're trying to do is how what ideas do you have, what more do you think come forward, but I think as Mike says it kind of it dries up because you try ideas. We don't get lots of people coming forward, so it is a difficult nut to crack, really. So, you know, we're always open to if people in those wards who understand those populations have got ideas, we're willing to try them, but we haven't found the magic bullet as such that's kind of making more people who haven't already come forward want to come.
Thank you very much. I cannot see any other hands up. So obviously noting the information and update that Mike's just given us, and similarly to our thanks for that first item around the data, to relay that to all of the work and effort, and as we say, very much ongoing effort in that vaccination programme. So thank you, Mike, to you and your colleagues and volunteers for all of that. That then takes us to agenda item 5, which is a report on living with COVID and looking at the response across the city to all of those pressures, which I know that Fiona is going to lead, and the other colleagues such as Mike I know will contribute. So I'll hand over to Fiona.
Thank you. So yes, we've got some slides again for this, and we've asked other members of the board to contribute to this. So it's really an opportunity to explain, as far as we know, what particularly the public health offer and what ongoing work we'll be doing around COVID will be after the end of March, but also to acknowledge, you know, potentially what some of the risks around that might be, and then also to give partners the opportunity as well to kind of highlight from their perspectives what they'll be doing, but also again where some of those ongoing risks might be, and then hopefully to have a conversation about whether we continue with this board or are there other mechanisms for ensuring that we have oversight around what's happening for the city. So if we go on to the first slide, I'll talk a little bit about public health and what our response around COVID will be, and just a bit of a reminder about where we started from, really. So back at the start, nearer to the start of the pandemic, clearly the Director of Public Health was responsible for leading the pandemic response, and fairly early on we were kind of instructed nationally that we had to have an outbreak plan that centred around 7 themes, and we had to have that outbreak plan published, and that we should set up an outbreak management board to oversee how that plan is being implemented, and hence why we're here today. And that was kind of our enhanced pandemic response, but that response will end at the end of March. So from a public health point of view, COVID will largely go back to being business as usual, as we would deal with any other infectious disease as a local public health team. So just thinking about those seven themes and what our response will be. So the first theme was around schools and care homes. So clearly, as the local public health team, we will always be on hand to they had a measles or any other infectious disease. So we're kind of the local team on the ground, and we've, particularly through COVID, built up really good relationships with our schools, and they know how to contact us, and we'll continue to do that. If there are kind of large outbreaks, they will be led by the UK Health Security Agency, and we have our local Yorkshire and Humber team who will lead any outbreak response, but quite clearly they will often come to us because we know the local area. So we have really good working relationships with our Yorkshire and Humber team, and we'll continue to do that. We mentioned a little bit before in terms of care homes. So care homes was one of those specialist themes that we had. And as we say, we're still waiting for some of the guidance in terms of what will be expected in a care home setting after the end of March, but we will continue to work with our colleagues in adult social care and the NHS to ensure that we continue to support whatever is required in that care home setting and make sure that they've got public health input into that. The second theme was around high risk places, locations or communities. So as a public health team, we have a responsibility to protect the health of our population and to assess any risk. So we will continue to work with partners across the city and make sure that we understand any specific risks. So, you know, throughout the pandemic, we've worked with various businesses across the city, particular populations, so for example the homeless population, etc. So you know, that is something we'll continue to do and is part of our duty as a local public health team. Onto the next slide, and the next area that we had a responsibility was around local testing capacity. So I've talked a little bit about all the work we've done around testing, but just to make it really clear, so our symptom-free testing offer that we delivered under the targeted community testing programme ends at the end of March. What that means for us in York is that our last testing site will close this Sunday on the 27th of March, and that will allow a few days of closing that down and handing that back. So that's our York St John's site. Foxwood and the University of York sites will close this Friday on the 25th of March. The PCR testing site, so that's Poppleton Bar and Wentworth Way, will operate up until the 30th of March, and then there will be no access if you have symptoms. So you know, if you have what you think might be COVID, we're moving away from that. Go and get a test to determine. So what we'll be asking people to do is, you know, whether you think it's COVID, whether you think you've got a cold, whether you've got a stomach bug, you know, it's moving to that. Let's just be really thoughtful about who we're mixing with and not sharing our bugs with people, because you don't know what vulnerabilities people that you're mixing with might have. So symptom-free and symptomatic testing essentially ends. It is likely that from the 1st of April, there will continue to be access to symptomatic testing for those over 80 or for particular groups who are immunocompromised, and that's about ensuring that they get access to antiviral treatment. And there may be symptomatic testing for some health and social care staff, and that's the bit that we're not really sure about as yet. So that potential future scenario where there's an outbreak picked up or a new variant identified in a particular area, and how you'll get potential access to testing at that point, that will be led by the UK Health Security Agency. Now, what they developed over the course of the pandemic, which we never had before for any other infectious diseases, was the ability to roll out really quickly mobile testing units. And we had some of those in York, if you remember. I think our first one was in Bishopthorpe in January 2021, and we had ones at Acorn Rugby Club, up in New Earswick. So we had various ones that rolled out at certain points in the pandemic where we had high rates, and we wanted to get that testing capacity very quickly into our local communities. So UKHSA have retained the ability to be able to roll out those mobile testing units if it should be required. I mentioned that our contact tracing service ceased to operate on the 24th of February. So if, for example, we had an outbreak and there was a need to do some contact tracing, again, that would be led by UK Health Security Agency. But again, you know, often they will come to us as the local people on the ground who know the organisations, know the city, and we will seek to offer mutual support to any future contact tracing effort as needed. On to the next slide then. So we had a theme around data integration, something that you've always had at these meetings. We've always started off with that data presentation in terms of all the data that we've collected, and our business intelligence team in York have done a fantastic job of managing all of that data and ensuring that it's there and easily understandable. And we've had a policy of being very transparent to our population. We've hosted that on the York Open Data, so that everybody is able to go and see, you know, what is happening in York. So clearly we won't be reporting on cases in the way that we have, because there won't be the testing, so that reporting will stop. From a national perspective, the ONS COVID-19 infection survey will continue, and that will become the most reliable source of knowing if infection rates are going up. The only thing to mention about that is because it's survey data, it's telling you what happened about two behind the curve. So locally, we will also still continue to look at that real-time data of what's happening in our hospitals. So working closely with UKHSA, who will also look at that data, but also our local hospital as well, and ensuring that we've got that good exchange of data, so that if we're seeing anything worrying, we can flag that to UKHSA to kind of say, look, you know, we're seeing something unusual here. And then the next theme was around vulnerable people. So within our plan, we had a duty to support people to be able to legally isolate where that was needed, but to make sure that they had the support to do that. So there was a lot of work that went on through our community team and the community hubs. Obviously, with the legal duty to self-isolate having ended, that particular piece of work has ended, but clearly we still have our community hubs who support vulnerable members of our community through lots of different work going on there. So if we go on to the next slide then. So the kind of last theme around that was, as I say, to have a local board. So we established this board to oversee that work and to ensure that there was political ownership, and also to provide that public facing engagement and communication out to our residents about what we were doing to manage the outbreak. And that was really important to have that. What we will continue to have, and where COVID will now be overseen from our perspective in the public health team in terms of monitoring it as an infection, we have a joint North Yorkshire and York Strategic Health Protection Board who monitor all kinds of infectious diseases, and so they will monitor the COVID data as well, and that's chaired by the Director of Public Health and the in the City of York, and jointly with the Director of Public Health in North Yorkshire County Council. We've also established a York only health protection group, which local dialogue that's become so important through this phase of the pandemic, to ensure that we are kind of picking up and any issues and making sure that we're supporting local partners as well. So both of those groups will include COVID. If there's any new variants, for example, or any outbreaks, we also have representation from UK Health Security Agency on those groups as well, and that's where we get that dialogue and call for any mutual support from the national infrastructure. So on that basis, our proposal would be that we would stand down this outbreak management board and leave it to those two boards to oversee the work of COVID. But obviously I'd be interested to hear what other partners think about that. And just finally, on the next slide, just to kind of aid in terms of maybe some of that conversation, just to kind of raise some of the risks, particularly for us from a public health perspective. So I've mentioned before, we may have a future variant of concern. We don't know what's around the corner. We really hope not, but we can't completely rule it out. We've talked a little bit here already tonight about vaccine inequalities, also other potential health inequalities that may arise from people who still continue to get COVID, whether they're unvaccinated or whether they have other health conditions that make them more vulnerable. With pretty much every health condition, there are inequalities, and we will see that with COVID. So we will be acutely aware of that as a public health team, and how do we work to ensure that we minimise those inequalities. I've talked a lot about if we have to stand back up a response if we have any local outbreaks or local issues. I'll be completely honest, we've lost a lot of our resource within the public health team that we've had over the last 2 years. So that's being done within a reasonably small public health team now within York. So, it would mean, if we had to do that, it would mean stopping some of our business as usual. So we just need to be aware of that. And of course, we probably still haven't seen all of the long-term impacts of COVID. So we've seen people with long COVID, but some of the broader issues of children who missed time out of school, people who lost jobs, all of those things, we're probably not seeing the full impact. So though I think there will be work for years to come dealing with what's happened in the last couple of years. But if we go on to the next slide, I'm going to hand over to some of our partners to talk through some of the issues for there. So I'll come first to Nimbus.
Thank you, Fiona. I think I'm trying to sort of divide this up into various categories, but obviously some of the things that we've learned from the pandemic have been how to work together within general practice and how to deliver at scale, and the advent of Nimbus Care has enabled that, really. So the fact that all the practices are now working together and have an organization that can hold contracts and deliver care at scale is potentially something that is going to be positive moving forward. We're also learning from how we risk stratified patients in terms of the vaccine program, and prioritize those at greatest need, and we're looking at ways that we can do that in the general population for ongoing health needs moving forward, and that may change how we deliver some of the services within general practice. We're now collaborating with other sectors. So the Children's Ambulatory Treatment Hub has been a real success in that regard, where we've co-designed services that previously had been delivered in hospital and now are delivering them off-site in the community from Askham Bar. And that's preventing young children from having to be seen in hospital and reducing activity in the hospital. And we're just now talking with commissioners about how that can be continued. We have also utilised non-clinical staff to deliver services. So we've had a single point of access for calling patients with COVID early in the pandemic, and now that's sort of morphed into a service for patients with long COVID, and that seems to be working really well. That sort of outreach, checking on patients' well-being, checking they have everything they need, and I'm sure that can be adapted for other things moving forward. Remote working, I'm sure, has been a factor right across the country. But in general practice, we switched models of how we consulted with patients very quickly, and that's been a good thing for many people, but others have struggled with that, and I think we recognise that. So we've used e-consultations, telephone and video consultations, and I think we've swung right over in one direction. And now the challenge is how far we swing that pendulum back. We get a lot of positives, a lot of compliments from people that they like that way of consulting and they like the ease of access, but clearly there are elements of the population who struggle with it, and I think we've just got to get that balance right, and we're in the process of finding that balance and doing it in a way that doesn't widen inequalities. We think that there is potential that it may even narrow inequalities, because it creates more space in practices for those people who are not tech literate. We're now starting to think about recovery and addressing the backlog. There's definitely a backlog in general practice. We see longer waiting times now for routine appointments, and we're starting to look at ways that we can reduce those waiting lists. And we're also working with the hospital and other colleagues to deliver sort of diagnostic services from places like Askham Bar. We've recently launched a spirometry service. There's a huge backlog of patients waiting for that, and we're now delivering that at scale from Askham Bar, and hopefully that will help us catch up. And we're looking at developing other services that will catch up on the backlog. For example, there are thousands of patients waiting for aortic aneurysm screening, which has been stopped during the pandemic. So we're looking at ways that we can introduce that into community care centres across the city. We've also been looking at ways we can support practices with urgent care, so doing some of that at scale, offering teams of people to go into practices when they're really struggling to manage that service and maintain that service, and that again seems to be working really well. We're building this principle of extracting transactional care from practices and delivering it at scale. So there's inbuilt efficiencies in that, but the key thing is that it allows practices to focus on relational continuity of care. So that patient-clinician relationship that we know has a significant impact in patients who have complex medical, psychological or social issues, or have multi-morbidity. We know that adds extra value. So we're working on that principle. And again, it seems to be having early traction. What I will finish on is the pressures in the system. There are huge pressures in the system at the moment, not only in primary care, but I imagine in social care and definitely in hospital care. We have huge numbers of people off sick with COVID and with non-COVID healthcare issues. And when you combine that with the increase in demand, it makes the system feel very, very pressured. And waiting lists, as I said earlier, for routine appointments in general practice are much, much longer than they would normally be, and much, much longer than we would like them to be. Capacity's certainly been outstripped by demand. And that's made worse by recruitment challenges. I think we're seeing that right across all sectors, that it's difficult to recruit people into these, let's be honest, lower paid frontline non-clinical roles. And, I've been outspoken during the pandemic about the relationship between the public and reception teams and other teams within general practice, the abuse that they have been receiving, and been saying that how unacceptable that is. Without pointing any fingers, I recognize it's difficult and we have to work together to address that, but it is a real thing. And I think perhaps as a city we can perhaps work together to try and get some messages out about how we deal with that. And I think the other thing we're facing is this shift of system. We're moving to the integrated care system. Our CCGs are going to cease to exist over the next few months, and that creates uncertainty in the system. I know Keith and key leaders from all stakeholders are working very hard to make sure that transition is as smooth as possible, but there's certainly some challenges ahead as we transition across, and I'm sure that will be felt at the front line by clinicians and non-clinicians alike. So I think I'll stop there. I think summarize by saying there's been lots of lessons that we've learned. I think we've evolved significantly over time, but there are clearly challenges ongoing, and we'll continue to feel them into the future. Thank you.
Thanks, Mike. So on the next slide then, we've got from York Hospital's perspective. So Lucy, I don't know if you want to run us through from your point of view in the hospital.
Yeah, thanks, Fiona. I can certainly do that. So much of what Mike's just described in terms of the pressures facing primary care absolutely are reflected in the hospital sector at the moment. living with COVID for us right now is a pretty difficult situation. We've got, as Fiona described earlier, we've got very high numbers of patients in all of our hospitals at the moment with who have tested positive for COVID-19. Again, as Fiona described before, whilst it's the case that by far the majority of those are not actually ill with COVID, the fact that we are still operating under the national guidelines around testing all patients at points of admission and at various points throughout their hospital stay, and then subsequently having to manage those patients depending on the outcome of whether they're positive, negative, or become a contact of somebody with COVID. Nonetheless, when you're dealing with those sorts of numbers, it does put an immense amount of pressure on our ability to run our hospital services in anything like approaching what we would recognise as normal business as usual. So it is causing a slowing down of flow within the hospital, so that is leading to delays with patients waiting to be assessed and seen in the emergency department, to be admitted, to be discharged, and unfortunately it is also having an impact on our ability to do and address our backlog of planned care and routine operations that we know we really need to address. That's due to the availability of beds for people once they've had their operation, because if we're seeing high numbers of emergency admissions, then unfortunately we do have to cancel some of those planned procedures. So we have seen some of that in recent weeks. The numbers of patients testing positive for COVID, they have exceeded the previous highest peak we reached back in January 2021. And since these slides actually were produced, unfortunately, the number has gone up a little bit. So they've been stubbornly high and don't, as of yet, seem to be coming down. So we are continuing to prioritise. I think if we can go on to the next slide, actually, there were two. Thank you. So we are continuing to prioritise that emergency and urgent work cancer cases and addressing those patients who've got the greatest clinical need. And despite these ongoing pressures I've described, we are making some progress in reducing the really long waiting patients, although we know we've got much to do there, and many patients are waiting much longer than any of us would want. So we're expecting some more guidance around testing, around how we manage in terms of infection prevention. So we're hoping that guidance might help us perhaps address this slightly differently as we start to get into a different way of living with COVID. But it's certainly fair to say that at the moment, living with COVID is particularly difficult in the hospital. Thank you.
Thank you. So we're going to come on to Alison next from a voluntary sector perspective. So if we bring up the next slide, and Alison, if you want to talk us through your slides, please.
Okay, can I have the first slide, please, or the next slide, please? Stop. Okay, thank you. So I think some of my stuff does mirror what Mike's been talking about in primary care. So some positive things that came out of the pandemic is the partnership working across the voluntary sector, but also across the whole system. So certainly the voluntary sector did a lot more work with other partners in the system, for example, with primary care. I think this voluntary sector was able to demonstrate how agile we can be and how responsive. And I think, really proud of the way the sector stood up and really provided some fantastic support to people in the communities. We know health inequalities were exacerbated during COVID, and we were able to come up with some creative ideas for targeting those most at risk, and hopefully we can take some of that learning forward through the next phase. So the ongoing response, Mike mentioned the COVID SPA, which is now the COVID Recovery Hub. So that was working with patients. And this is, again, a continuation of the partnership working that we've done. This is continuing to monitor people with long COVID or suffering the effects of COVID. We now have grant schemes to go out to people, to groups, again, who have been impacted in the worst way by COVID. And we continue to support people who have been impacted physically and with mental health issues. We know all about the issues we have with mental health, and that takes up quite a lot of the work for most of us in the sector. Next slide, please. So just looking at some of the challenges which you've heard me talk about before. So the people that are coming to the voluntary sector have more complex issues. We've seen lots of people falling through the gap and not getting the support that they need when they need it. So to enable us as the VCSE to support these people, there is a real issue with workforce and training. We need more training in the sector to enable us to work more with these people who have complex issues. And workforce is a challenge, the same as everybody else. We've got a third of our workforce off at the moment with COVID. That's just at York CVS. So we are all seeing worse than ever the impacts of COVID, and we're all just waiting to go down with it because most of us had it already. So it's proving to be very challenging at the moment. System pressures, demand is high, capacity is not necessarily increasing to match this. We've got increased demand, which leads to the waiting list that might refer to people falling through the net and not meeting the thresholds again, which have increased in order for the system to cope with the pressures. So a bit of doom and gloom from the voluntary sector, as always, but there has been some really positive partnership learning coming out of it. And I think as we enter the new world with the health and social care changes, I think it's put the VCS in a good position because we've become quite key players and partners across the whole health and care system. Thanks, Fiona.
Thank you. And then Charlie, from a university perspective, if we go on to the next slide.
Thank you very much, Fiona. It's been a fantastic collaboration between the four institutions: University of York, York St John, York College and Askham Bryan College, working with the council and with Nimbus Care. Carol Runciman has kept us in good order. We were meeting for a long time at 8 o'clock every Tuesday morning to make sure we were able to think through the issues and respond to them effectively and in good coordination. So it's been a brilliant collaboration over the period. We're now in the living with COVID phase. We're not losing our focus. A lot of focus still on vaccination, and we'll keep that as a strong focus, working with Nimbus Care over the next months and into the next academic year. Probably the biggest concern is around those who are clinically extremely vulnerable, and how we do what we can to mitigate their risks as society opens up in a more general way. So we're all thinking very much on an individual basis, looking at assessments of working conditions, studying conditions and the mitigations that we can put in place. But we're doing that now through business as usual processes within our various institutions. So falling back into how we used to deal with health risks before COVID. And similarly at the collaborative cross-institutional level, we are now working not through our subgroup of this board, but through the Student Health Network, which pre-existed COVID and which now will become the forum in which we consider whatever twists and turns that COVID throws up for us. If we could move to the next slide, please. Thank you very much. Still quite a bit to think about because we've got plenty of cases, and in terms of relative to size of population, we have rather more staff cases than student cases now. So we're still having to deal across the institutions with the challenges that causes. Thankfully, very, very few seem to be getting genuinely ill. Most cases seem to be really quite mild. Lots of anxieties we have to deal with as we go into that world where wider mitigations have been removed as guidance and as regulation. Looking ahead, there is a moment of risk when our new academic year starts, reconvening people from different places, from different countries. Every year before COVID, we used to have an outbreak of typically respiratory diseases of some kind or other, and it'd be quite a challenge to distinguish what's standard freshers flu from COVID, and in practical terms, we won't really be able to distinguish. So I think the emphasis will be very much on carrying forward the effective general public health messages that have become part of our repertoire in COVID around hygiene, but also around keeping away from other people when you're feeling poorly. And I think that's going to be crucially important. Last word, thanks to the team. It has been such a pleasure in really difficult circumstances, working with Sharon, with Fiona, and the others who were part of the group at various points, Nick Sinclair, Peter Roderick, Jen Irving. They have been both patient and brilliant. And I think they've cemented a really powerful collaboration across the 4 institutions and City Council and Nimbus Care. And I'm tremendously grateful for the commitment that people have shown, and also the really good working relationship among some people who've never been in the same room together. And as a final flourish, we are going to have an event when we are all in the same room together, and it may involve some fizz, as we will convene to reflect on what's been an extraordinary experience, but I think one which shows the spirit of the institutions in our city. Thank you very much, Fiona.
Thank you. So, Chair, that's all the slides that we have, but I am conscious that there are some other partners on the call who may wish the opportunity to offer any of their reflections from their areas of work.
Thank you, Fiona. So if anybody else does want to add anything from their perspective, please indicate and do so. And obviously, thank you for that presentation and the contribution that all the different organisations have just highlighted, which I think goes back to that thank we expressed at the start of the meeting. One of the suggestions, obviously, in that is the Outbreak Management Board does not meet. So in so doing, I'd like to again place on record a thank you to all of the individuals, organisations, substitutes that have contributed to that work over a long period of time now. In the pack that was just presented, it set out a number of systems where that particularly public health work would be picked up by officers. I think the other question to consider is where we, as the public facing board, would like the public health issues to be addressed moving forward if the Outbreak Management Board doesn't exist. And there are a number of suggestions for this. We're obviously working together with health partners on the York Health and Care Alliance, which would be one place where some of those issues could be discussed. But I think the best suggestion would be the Health and Wellbeing Board, because obviously that is a public live stream meeting. Carol chairs that. And I think that would be a good place to include some of these issues and make sure that it was part of the work plan of the Health and Wellbeing Board moving forward. But similarly, if the Health and Wellbeing Board at any point felt that we needed to have a one-off, for example, or urgent meeting of the Outbreak Board, that we had a mechanism to do that and to get back together quickly, because I think equally Fiona's presentation highlighted the risks, and I think having that option would be really, really sensible. So I'd welcome all of your thoughts on those sort of structures moving forward. I'll go to Carol first.
Thank you, Chair. That seems a very sensible way forward to me. The Outbreak Management Board can certainly keep an eye on the situation. We can have it as a regular agenda item, and we can notify you or whoever is appropriate if we feel that the Outbreak Management Board needs to reconvene. So as Chair of the Health and Wellbeing Board, I would accept and welcome your suggestion.
Thank you, Carol. Alison.
Yeah, I totally agree with that. And I think there might be other boards as well that might want to pick up some of the other issues. For example, the Human Rights and Equalities Board, when it's back on track, might look at some of the impacts on those with health inequalities. So I think it's not just the Health and Wellbeing Board, it might be other boards as well might want to look at some of the specific issues that are relevant to those groups.
Thank you, Carol and Alison. And similarly, I could see various nods on the screens when that proposal was being suggested. Fiona.
Yeah, I'd agree with that proposal. I suppose the other thing that I would offer as well is, yes, there are other groups who will have an interest and at periods may want to get an update, and as a public health team would always be happy to come to other groups to give that kind of update in terms of what has been happening around COVID. So that would be a ongoing offer that our team will do.
Thank you very much. So I can't see anybody disagreeing. Oh, Pete?
Not disagreeing. I've got a question on the presentation when we get to it.
Please, yeah.
Yeah, okay. Just it seems to me from, and thank you very much everyone for not just your presentations, but all the work that you've done over the last 2 years. It is greatly appreciated. And as has been said, you've done, it's been a fantastic job, and it's great to see those silos breaking down, and let's hope they stay broken down. Just now that we're in that sort of interim period, between the restrictions being relaxed and the new guidance coming out, etc. I'm just curious as to what public health advice we're giving. So, for example, what public health advice are we giving to people who are testing positive for COVID in terms of what they should do, in terms of isolation, etc. And in terms of vulnerable people, are we, now that the symptom-free testing's gone, are we still advising people that if they're going to be in the presence of vulnerable people, they should lateral flow test first? Are we still giving that kind of advice out?
Okay, so the advice so we're still in the kind of outbreak response, as it were, until the end of March. So there is access to testing at the moment. So clearly, if people are testing and they test positive for COVID, whilst there isn't a legal requirement to isolate, the guidance says you should isolate for 5 days, and that's, you know, and we have that kind of guidance, for example, in schools, where, you know, if children have chicken pox, for example, they should stay off school for a certain period of time. So it's following that guidance as we do for other infectious diseases. Obviously, after the end of March, there won't be that access for testing, and it is moving to that new mindset of that we don't have to test for everything everywhere we go, and that is because of the vaccination program, and I sort of referenced earlier that it is a difficult mindset for people to get into. So we started in, you know, earlier on in the pandemic, when we really didn't know very much about COVID, telling people that they were clinically extremely vulnerable, they had to shield, and at the time that was absolutely the right thing to do. As we've learned more about the virus, so we know more clearly now who are the vulnerable groups, We've got a vaccination programme, and we also have good treatment through antivirals. So actually, the people now who are still vulnerable is a very small group who will be under the care of clinicians. So people who, and I can completely understand, if you were told you are vulnerable to this, that's hard to get out of that mindset to move to feel reassured. But actually, all of the evidence points to, with the treatments, with the vaccination, and knowing what we know and the way that the virus has evolved, that those people are not particularly any more vulnerable if they have been vaccinated. So the message really is that we are moving to that new way of living with COVID now, and that we have to try and give people the confidence to get back into normal life, because actually what we need to do is weigh up what is the risk from COVID and what is the risk from people feeling that they're isolated and can't go out. And arguably the risk from people kind of living in that very closed way and that fear is more than the risk that now COVID presents to them.
So, the question really was more along the lines of people who are caring for vulnerable people. So, so you're visiting somebody in a care home, or you're working, or you're looking after somebody that was immunosuppressed. Should you be testing still regularly before you come into contact them? That's sort of, it's all starting to get a bit fuzzy.
Yeah, so it's, I mean, as I say, we are waiting still for some of the guidance around very specific settings. So, for example, care homes, but it is likely that symptom-free testing will disappear completely. We never did it before for any other conditions. So, for example, previously, if you were caring for a person in a care home, they would have equally have been vulnerable to any infections that you might have taken into that care home. So good hand hygiene is important, not going into those settings if you feel unwell, but not having to do the routine symptom-free testing. That's what we'll move to. So no, we won't be recommending in those situations that you do routine testing, and that is a big shift.
Sian.
Yes, I just wanted to add to the voices saying I think it would be really great to explore the ongoing issues through the Health and Wellbeing Board. We meet regularly, we can pick things up, and if we need to reconvene this meeting, we can do that. But I was really interested in what Fiona was just saying about the messaging for people who have been advised previously to shield, and the balance of preventing further health damage to people who haven't been able to access services because of the pandemic, and weighing up those sort of impossible medical conundrums. So I guess I was wondering, do we have access to, when people ask you questions about stuff like this, I know there's huge amounts of research out there. There's some really good data that explains the shifting things throughout the pandemic, and why right now actually the best thing to do isn't to keep up the testing and to isolate and to stop us all kind of getting back to something like normal. But do we have anything simple that you could share with other members of the board, so that when we're facing questions from people, we have at our fingertips something that actually helps us explain this in a way that is much more useful than anything I would put together about why we're changing the approach to COVID? Is there something we could all have access to that would help us with that?
Yeah, to be honest, I don't think there is, and that's a really good point. So that's something I'm happy to take away, to do just a kind of very simple explainer, that, like you say, just has those kind of key messages. So yeah, I'm happy to take on board doing that, because I don't think it exists in one clear place at the moment.
Thank you very much for that. So obviously we'll note the update, noting the fact that this would be the last meeting of the Outbreak Management Board, but that those issues will be picked up by both officers and councillors in those other places, including the Health and Wellbeing Board, so that residents can continue to see that and have access to that information. But that obviously, given the risks outlined, that will reserve the right to bring back the Outbreak Management Board for a particular meeting or ongoing, should that be needed. And then just at that stage, again, like to repeat my thanks to everybody that's been on the board. And I wonder if we should ask Tracy to send round some notes of thanks to those who have contributed and those organisations, including some who are not on the board at the moment, to mark that. So if you're all happy, and don't say that you're not, I'll speak to Tracy about making sure that that can happen outside of this meeting. That then takes us on to agenda item 6, which is any other business. So I'll just check with anybody if you have any other items. And obviously we've covered the thanks elsewhere as we've gone through the different items. Fiona.
Yeah, sorry, it was just on the back of thanks, really. There has been a lot of praise for the public health team tonight, so I want to thank people for that, and clearly I will take that back to the team, because it has been a whole team effort. So I will make sure that they are aware of the thanks that people have given to them. But also just to say, we couldn't have done what we've done if it weren't for our other colleagues in the council, but also colleagues in the NHS, the voluntary sector, the education sector, the business sector, and of course remember what was Public Health England, now UKHSA. So we were only able to do that because everybody else supported us. So I wanted to note our thanks back as well. Thank you.
Excellent. Thank you for that, Fiona. A nice point to finish on. So just to thank you all for attending tonight's meeting. I look forward to watching the Health and Wellbeing Board pick up some of those issues in the weeks and months to come. Thanks all. Bye-bye.